All right, welcome everybody. So for those of you who don't know me, I'm Samantha Bellinger, and I am the VCHIP program specialist that works with the PQC. So thank you all for joining us today for our PQC webinar on gestational diabetes management. So Dr. Meyer and Dr. Horn will be presenting today. But before I turn it over to them, I do want to go over a few housekeeping items. Marge, can you advance the slide? Thank you. So one of the things is that I will be monitoring the chat throughout this presentation. You are also welcome to use the hand raise option as well as unmuting and asking your question verbally. And speaking of mute, you all should be muted upon entry. We ask that you all stay on mute throughout the presentation unless you're actively asking a question, just to cut down on the background noise. As you all can see, this is being recorded, so you will have access to this at a later date. And we have captioning for this webinar. So if you go down to the bottom of your screen and click Show Captions, if you can't see it automatically, it should be under your More section. And then also for the evaluation, so before on the slide, it says you'll get the evaluation before leaving the event. That's not correct for this one. I will be sending out the link for the evaluation as well as the recording later this week. So, and also, if you have not already, please join our PQC listserv. So the email is there on the screen. I'll also make sure that you all have that during the email I send out. And I think that is it for housekeeping. So I'm going to turn it over to Marge.
Well, thank you guys. And sadly, neither Delia nor I have significant disclosures, but we do have a price. So if you want to pay us, well. So today, we're going to just mostly focus on intrapartum care and newborn care for gestational diabetes. And I will tell you, I focused on this for a reason. One is I realized even within our institution, there's a fair amount of variability about how we follow people in labor and their glucose control for gestational diabetes. But more importantly, I know that there's variation across the state of who feels comfortable delivering people within their institution, of women that are on medication for gestational diabetes. And so I wanted to provide data because I actually think that the data would suggest there's no reason you can't deliver them there. I realize you may need some support from MFM in other ways. And we can talk about that too. But that was really the focus of this particular talk. So first, I love this slide because, again, it tells you how the definition of gestational diabetes, even now, is pretty well all over the place, right? ACOG insists that it's when a condition in which carbohydrate intolerance develops during pregnancy, but of course you don't know that because we don't test for it. The ADA, the American Diabetes Association, is a little more thoughtful and says, look, if you diagnose it at 8 weeks, it's probably not pregnancy related. And it's probably type 2 diabetes or at least a pre-diabetes situation. So I will tell you, there's not even consensus on this, but for the purposes of this talk, you can use whichever diagnosis you want, but most of you guys, if you happen to identify either a high hemoglobin A1C or very early abnormal test, you just send them to us anyway, which is totally fine because we treat them more like they have pre-existing diabetes. So I actually kind of favor the ADA one because if you identify it at 8 weeks, it's probably not pregnancy related. So here's the outline of the talk is how should people with a diagnosis of gestational diabetes be prepared for labor and delivery, which I realize I might not have actually included in this particular slide set. How do you perform testing intrapartum? Should people treated with insulin and or metformin be assessed differently? That would be compared to people who are just diet managed. How do you react to them? But most importantly, and what started a lot of this, were two concerns. One, that people with gestational diabetes might need an insulin drip in labor and therefore couldn't stay at their institution, because I totally understand nobody wanting to run an insulin drip on somebody. And second, not wanting to keep the mom because of the concern about severe neonatal hypoglycemia and the needs to transport. So those are actually the two most important things. And so we're just going to talk a little bit about the level of maternal care. And for the neonatal care, Delia, of course, is going to talk about that. But how should neonatal glucoses be assessed and treated? What factors affect neonatal hypoglycemia, and what level of care is needed for the infant of the person with gestational diabetes? So first, I just want to keep reminding people about what maternal levels of care is, except for our institution, which is level 3 to level 4, depending on which anesthesiologist you talk to. That's a long story. But pretty much every other hospital in the state is a level 1. And pretty much this just basically, you guys actually already know this, but in terms of basically being able to do very standard, comprehensive OB care. And people that are physicians, it obviously doesn't say anything about diabetes or medical complications, mostly just that you have certain supports available. And we've gone through this exercise, and everybody does meet this level 1 basic care level of care standard. As you know, the PEDS people, of course, were years ahead of us on this and established levels of care. And this is basically what level 1 level of newborn care looks like. And I'll let Delia talk about that more later. But also, all of your hospitals in our state are level 1. So in terms of the treatment of diabetes, as people know, diet, medications can include metformin or insulin and metformin. And you know, a good question is whether or not people are in good glycemic control during their pregnancy. And there's actually less consensus around here than you would think. However, in general, most people feel that a fasting glucose of less than 95, although some people use 90, a 1 hour postprandial of less than 140, or a 2 hour postprandial of less than 120. For people that are just on diet, we usually watch and assess them a couple of weeks, and then we reduce their frequency to 3 days a week if they're stable. We do start medication with any abnormal glucose values, and I have greater than 50% abnormal, but I will tell you that the data are actually, we're probably a little more generous than we should be. We should probably be a little more aggressive about starting medications, because you're going to reduce your risk for macrosomia. And anybody taking medication should have a fasting and a 1 or 2 hour postprandial done every day and after each meal. So when I started looking for intrapartum glucose monitoring recommendations, it was actually kind of shocking how little data there are. Almost everything references risks and problems associated with pre-existing diabetes. ACOG in their recommendations is completely silent on intrapartum glucose assessment. And even this came from this analysis through the Brits on consensus management. And even they, when I looked at their evidence-based guidelines to see what data they pulled their data from, there was nothing, and I mean nothing. They talk about intrapartum sugars should be between 70 and 125, but there's no data really about the impact of that. So does intrapartum glucose control. And again, I focused on this because of people's concerns about needing to manage insulin, specifically insulin drips in labor with gestational diabetes. So the question is, how often should we check the glucose? Does it matter if tight intrapartum control matters? And the most important thing, because you'll see this all the time, is that maternal intrapartum control immediately translates into how the baby does relative to hypoglycemia. I'm going to show you a ton of data on that, but I will cut to the chase and say, nope, doesn't matter a bit. And when you think about diabetes, it makes perfect sense. These are babies that are chronically exposed to hyperglycemia. If moms are not in good control, if they're really big, what happens during a pregnancy, super important. What happens during labor and delivery, not really that important. So I just wanted to put that, I'm going to show you all that data, but I figured I'd give you the punchline. So we actually had virtually no data on this until they published a study in 2019, which again is shocking in the relatively few people it had. I'm going to show it on the other slide. I can't remember, but there's hardly anybody. Anyway, about 2/3 of each group, they randomized people into what they called a very tight control, which is they tested people in labor every hour. And if you had 2 values over 100, they gave them some insulin. So that was a super tight control group. And they only started insulin infusions if somebody was over 200. I can tell you now they didn't have anybody. The liberal control group only had testing every 4 hours. And if you had more than 2 values over 200, you considered insulin drift. But if you had an elevated glucose value, if it was between 100 and 150, you got 2 units. And again, that was just sub-Q. And if you're between 150 and 200, you got 4 units. So not as much insulin, not as much antenatal testing. But here was not that surprising that it didn't make any difference, but what was surprising is that the people that had tight control actually had, not surprisingly, the moms had more insulin, and they had more finger stick testing, but there's also more maternal, I forgot to bring this down, more maternal hypoglycemia, even though this was not significant, it was double. But more importantly was the neonatal outcomes. There was no difference in the initial 2-hour glucose test, which is when they did it in this one, but they did have more interventions for hypoglycemia in the people that had tight control versus liberal control. And even though, so the babies' blood glucoses were slightly lower in the very tight control group, and everything else was technically the same, but tended towards, but was very clearly equivalent between the two. There was actually higher IV intervention in NICU for hypoglycemia in the tight control group. Again, not statistically significant, but this was 13% versus 3%. The bottom line is clearly very tight control did not help with neonatal hypoglycemia, and in fact, could have made it worse. So based on, these are again considered, they should be considered level A data, right? This is a randomized trial. The women for GDM, there's no benefit to tight control, and it supports testing your glucoses every 4 hours. I'll be honest with you, if they're on diet, I'm not even sure that's necessary, but only intervene if the mom's blood sugars are low, which again, if they're on diet, it shouldn't really matter, or greater than 120. So then this was a review paper, and Delia's going to show the pediatric side of this, which is and this study just asked the question about whether or not strict intrapartum glycemic control is the key driver in neonatal hypoglycemia. And so the primary objective of this study was not so much the maternal control, but to evaluate the incidence of neonatal hypoglycemia and NICU admission in people that had an immediate pre-delivery glucose that was considered hyperglycemia, which was defined as over 110, versus those people that were normal. And they wanted this paper also wanted to know whether or not it mattered if moms were pre-existing or not. I'm not going to go through the pre-existing data. That's why I highlighted these. We're only talking about this cohort of people with gestational diabetes. About half were diet controlled and about half were on medication for their GDM. And then they looked at the neonatal outcomes and separated those into those moms that were hyperglycemic before delivery versus euglycemic in each group. And so what they found, what they did was they measured capillary glucose every 2 to 4 hours in early labor and every 1 to 2 if people were on medication. If they were just diet controlled, they just did it every 4 hours. But they did flip them into a more frequent group if they were elevated. And they gave IV insulin, and I wrote IV, but it's not, I can't remember if it really was IV or sub-Q, I have to look. Was initiated if the maternal glucose was over 110 on 2 consecutive occasions. So still a relatively low blood sugar. But what they found, the primary outcome of this study was neonatal hypoglycemia. They defined that as less than 45. And then they did the secondary outcomes of neonatal hypoglycemia. The primary outcome was the first hour of life. The secondary outcomes were the 2nd to 24 hours of life, or NICU indication. So basically, their findings were that the rate of hyperglycemia in labor was the same for the moms if they were on diet versus medication, just a little over 10%. So that would be point number 1, is that it actually doesn't matter if you're diet controlled or medication controlled, your incidence of hyperglycemia of moms identifying as hyperglycemic in labor may be about the same. The second, so what this study shows us is that hyperglycemia prior to delivery is not even that common, just a little more than 10%. Only about 10% of women received insulin in labor, and their range was really quite low, and some people would argue whether or not they had a very low blood sugar of 110. Most people would be at least 120, and their mean was less than 120. That the newborn hypoglycemia was resolved in all cases without NICU admission. And the only thing that flagged was in the hyperglycemic group, there were more NICU admits, but they were not related to glucose control. And the only thing that flagged was a slightly higher rate of neonatal hypoglycemia at 1 hour, but it resolved in all cases with no NICU. So the conclusions from this article were that strategies other than strict intrapartum glucose control are necessary to reverse adverse neonatal outcomes. And again, this makes a lot of sense. And what this basically translates into is optimal antenatal control, but intrapartum controls is definitely less impactful. So this last study was again looking at neonatal hypoglycemia, looking at diet-controlled versus insulin-treated gestational diabetes. And again, all they did was they took these 2 cohorts, so it was not necessarily an intervention study, but looked at whether or not there was a big difference in diet control, the infants of moms delivered of diet controlled versus moms on medication. In this particular study, they just used insulin. And the point of this graph right here is just that these numbers are the same. So it does not appear that the addition of medication for gestational diabetes is an important factor in whether or not babies are going to have significant hypoglycemia. The major risk factor by far for hypoglycemia was LGA. And the indication, the NICU admissions almost all had indications other than hypoglycemia. And this is just a graphical representation of the birth weight centiles. So you can see that this LGA group is more common. It's more common to have severe hypoglycemia, but that does not necessarily, and that was just defined as less than 36, does not mean that they needed the NICU. And even still, it's just a quarter of those babies. The rest of them, even with macrosomia, did not require a lot of interventions. So it's not it looks like these babies in general can be managed without a NICU. So I do talk to patients actually about the way to reduce the risk for gestational diabetes. But one thing I probably don't talk enough about is their gestational weight gain, which actually I do, but they all get mad at me. But I do think it's still important to really talk about it. So first, we want optimal antenatal control, but the best way to avoid an LGA infant is going to be by avoiding excessive gestational weight gain. The people that gained less than the recommended weight gain, and they only follow them after the diagnosis of GDM. But those people, and we know who they are, right? We see them all the time. You start them on the diet, and they'll come in, and a lot of them are in that overweight to level 1 obesity category. Once they have a diagnosis of GDM and you put them on a diabetic diet, it's super common to see weight loss. I actually tell people that it's super common for women in those weight ranges to lose a little bit of weight. And if they gain less than the recommended weight gain, they have a reduced risk for LGA macrosomia. And I can already tell you, based on all the other data about weight gain, it does not make their neonatal risk higher. It only reduces it. On the other hand, if women continue to gain excessive weight after their diagnosis of gestational diabetes, that's when they had an increased risk of LGA and macrosomia and cesarean delivery. So when you have your patients with gestational diabetes and they really, really want to minimize the risk for hypoglycemia, and by the way, for cesarean delivery, the thing to really have conversations about is this issue of gestational weight gain, which, as you guys have heard from Julie Phillips for years, this is a difficult thing to do. I am not here to say that we know for sure the best way to avoid excessive weight gain, but it is probably related to both diet and exercise. So these are the more important things than intrapartum. So the take-home messages here is that gestational diabetes with treated with diet or insulin both have low rates of maternal hyperglycemia and low rates of requiring insulin labor, and those that do can be done with like single dose. Very few people need them. And that newborns delivered of patients with gestational diabetes also have very low rates of NICU admission directly related to hypoglycemia. And there's no clear difference in women that were treated with diet versus insulin. Tight intrapartum control doesn't make things any better, and in fact, it might make things worse. Few people, even on medication, will need insulin labor, well less than 10%. One studies about 3%. And excessive gestational weight gain is really associated with macrosomia, which in turn is associated with neonatal hypoglycemia. So I feel like there's a fairly robust level of evidence that would support this kind of an algorithm. I always like to put an algorithm up for people that are diet controlled, check their sugars every 4 hours, I would say, or none. I would be comfortable with that personally if they were well controlled and had a properly grown baby. You can decide to create an algorithm in which their blood sugar, if it's over 120, to give them a small dose of sub-Q insulin. It's certainly, if you give them some insulin, you should check it every hour for 4 hours, but don't retreat them with any insulin until 4 hours have elapsed. Postpartum, you don't need to do any glucose assessment. You don't need to do any finger sticks afterwards, but just do either a 2-hour test, either immediately postpartum. There's a fair amount of literature for that. 6 weeks later, or hemoglobin A1C at 3 months. If you're on gestational diabetes and you're medication controlled, and I have another slide that just talks a little bit about medication antenatal control, Even if you plan to deliver your institution, MFM is happy to do the medication management. We do it for a lot of people. You probably should test them in labor every 2 to 4 hours, and you can increase that to 1 to 2 hours, depending on the results. And again, small amounts of insulin, should your sugars be high, which is exactly what it is on the other one, and exactly the same in terms of retreating, in terms of checking every hour after 4 hours. And postpartum, as long as you don't suspect pre-existing diabetes, we usually check a fasting on postpartum day 1. Even that is probably overkill. But you can consider doing the GTT again prior to discharge. We don't do it as much in this group because we have more failures, or wait for 6 weeks and a hemoglobin A1C at 6 months. And just to remind you, in terms of the antenatal proposal for you guys, in terms of how we can help, when you make your GDM diagnosis, you just send them to us if you expect pre-existing diabetes. That's usually the very elevated hemoglobin A1C early in pregnancy. Otherwise, send them to nutritionists. We have them check your finger sticks, and fasting in 1 to 2 hours postprandially. If they have good control, routine OB care. If more than 20% of the values are abnormal, just send them to us. So we'll consider medication, and then you start antenatal testing and consider induction. If they have very poor control, consider induction at 38 weeks. And I would say these are the kind of people that we can talk about where to deliver, although the data would still suggest most of them can be managed without a NICU. And MFM can happily co-manage. We do this all the time. People just send their glucoses to us. We manage their medications. We do have visits every 2 to 4 weeks, depending on, but a lot of them can be telemed, depends on where they live and things like that. But we try and minimize their travel time so that they can stay there, and we just expect medication discontinuation at delivery. So with that, I'm going to turn it over to Delia to talk about the baby.
Thanks so much, Marge. So hi, for anyone who doesn't know me, I am Delia Horn. I'm one of the neonatologists up here at UVM in the medical center. And I'm going to be talking a little bit about some of the things that Marge touched on, just sort of the effect on the baby of a gestational diabetic mother, but then really focusing on the care of the neonate with hypoglycemia. And in particular, talking a bit about some of the management that could be done at the level 1 newborn nursery level. So next slide, please. Thanks. So this was a meta-analysis that came out in 2022. And really just what I want to highlight here is that every one of those numbers that you see on the middle of the screen represents a study that was included in the meta-analysis. And they looked at all these other adverse outcomes, which you can see the majority of them pertain to the neonate. And they looked at whether these adverse outcomes were increased in pre-gestational diabetes or gestational diabetes. And as you can see, just the enormous preponderance of the evidence is that these things are increased in pre-gestational diabetes. There are very few studies that found that they were increased in gestational diabetes, and a few studies that found that they were increased in both. But again, the vast majority of these adverse outcomes are things that you're going to see if mom has diabetes that's pre-existing the pregnancy. Next slide. And Marge already went through the TUBA study in quite a bit of detail. I'm just going to highlight a couple of the things related to the neonate. Most importantly, that neonatal hypoglycemia was seen in the gestational diabetic mothers who required medication, but only at the 1 hour mark. So it was not seen at 2 hours or further after delivery. So this really was not persistent neonatal hypoglycemia. This was easily treatable and quickly resolved. And it wasn't seen at all if the mom's gestational diabetes was diet controlled. And then just, to focus kind of back on pre-gestational diabetes, that with those patients, they saw that regardless of the intrapartum glucose control, that there was an increase in neonatal hypoglycemia and an increase in NICU admission. And then also for patients with pre-gestational diabetes, they were much more likely to have an LGA baby. Patients who had gestational diabetes, their babies were likely to be AGA. So when it comes to treating neonatal hypoglycemia, my kind of mantra or sort of, guiding approach is to advance fast and wean slow. And what I mean by that is that if you have a baby who has hypoglycemia, certainly persistent on more than one check after they're born, you really want to quickly advance your care to capture them and get them euglycemic. So I really don't muddle around very much with these patients with, finger feeds or cup feeds or SNS or things like that. If you have, oral glucose gel, if that's something that your center has, that can be used. Formula is very controversial here in the state of Vermont, but certainly you're going to get a more consistent amount of carbs into the baby if mom's milk hasn't come in yet by supplementing with formula than you will by supplementing with donor milk, which oftentimes doesn't have quite as much carb content. And I think sometimes this is a time to have a real honest conversation with a family about what are the risks of, supplementing with formula for a few feeds, maybe even a few days, versus what are the risks of the baby needing to be transferred up to the NICU up at the University of Vermont, being separated potentially from the mother for some period of time, being in our NICU where it's more difficult to do skin to skin and breastfeeding and bonding and those sorts of things. So I think sometimes just an honest conversation with the family can help to get them on board with supplementing with a couple of feeds of formula. And then what we do at the University of Vermont in our NICU, and something that I would recommend if it's something that your center will be able to support, is fortifying breast milk feeds. So in the hypoglycemic babies, we'll often try to just fortify a breast milk feed with Similac up to 24 kcals per ounce to get those extra calories into the baby. And sometimes by doing that, again, if that's something that your center can support, that can get them to a euglycemic state without further interventions. But of course, if you've tried all of those things and the baby is still hypoglycemic, it's time to start IV fluids. We usually recommend starting with a D10 bolus, which we do 2 mLs per kilo. And then for term babies, starting D10 fluids at between 60 to 80 mLs per kilo per day. And if you're leaving them on that, monitoring their electrolytes, adding electrolytes as indicated. And then of course, in conversation with us, if they're persistently hypoglycemic, maybe increasing those IV fluids if they're otherwise stable and you're comfortable keeping them at your center. So I did want to focus a bit on how to wean the dextrose containing fluids. And I think that this could be valuable for folks who are trying to keep those babies, at the center where they were born, trying to avoid a transport in a baby who's otherwise well appearing and doing well. And this is something that, I've heard from the community, folks would like a little bit more education on. So your plan for weaning the IV fluids really has to be driven by the glucose infusion rate of dextrose that you have running, and also by the baby's euglycemia or maintenance of euglycemia. So what we do up at the University of Vermont is we'll wean by either a half or a full MKM of their glucose infusion rate every time they have 2 subsequent pre-feed blood sugars that are greater than 55, or a pre-feed blood sugar that's greater than 70. And then we'll wean the fluids by that 1 MKM or that half an MKM from the rate that they're currently running. And in order to do this, of course, you have to know what your glucose infusion rate is, which you can calculate using that complicated little formula at the bottom of the screen, or you can do what most of us do and go to the free online calculator that Cornell puts out that is really quite easy to use and good at giving you your glucose infusion rate. The other thing that you'll see from this slide is that you really do have to be monitoring pre-feed blood sugars in order to do this. So if you've got a baby who's an infant of a diabetic, and you're, monitoring their hypoglycemia and treating it, you need to be checking their glucose before every feed. So that's a screenshot from the online glucose infusion calculator. And I thought I would just take people quickly through a little sort of case example of how we would recommend weaning the fluids. So if you have a 3.8 kilo term male infant, they're on 100 MKD of D10 with electrolytes, they're doing well, and they've had euglycemia over several checks with that. So you know that your 100 ml per kilo per day fluid rate means that your fluids are running at 15.8 mLs an hour. You go to the calculator, you plug in that they're a 3.8 kilo baby, always using their birth weight because we know they're going to lose weight over those first few days. And then you plug in your fluid rate of 15.8 mLs an hour of D10. And the calculator tells you that your glucose infusion rate is 6.9 mkms. So you know that you want to reduce your rate, the mLs per hour that you're running the fluids, by the equivalent of either 1/2 or 1/2 of that glucose infusion rate. So you want to go down to about 6.4 or 6.5 mkms to reduce by 1/2, and you want to go down to about 5.9 or 6 mkms to reduce by 1 mkm. So this is just kind of a little example of how you would do that. And honestly, when you're looking at the calculator, you just plug in different fluid rates until you see the GIR that you want. So you maybe, we started at 15.8, I might put in 15.5 and see where that got me, and then put in 14.5 and see where that got me. So I found that with a D10 rate of 14.7 mLs an hour, I now have a glucose infusion rate of 6.4 mkms. So that's a decrease of 1/2 an mkm. And I saw that if I had a fluid rate of 13.7 mLs an hour, that drops my glucose infusion rate from 6.9 to 6 mkm. So that's a drop of about 1 mkm. So, yeah, thank you. So by doing that, you can see that, okay, if I drop my rate by 1 ml an hour, I'm going to decrease the GIR by about 1/2 an mkm. And if I drop my fluid rate by 2 mLs an hour, I'm going to decrease my GIR by 1 mkm. So then you'll follow the baby, you'll follow their pre-feed glucoses. And every time you have 2 in a row that are above 55 or one that's above 70, you'll drop your fluid rate by that amount, by either 2 mLs if things are going well and they're really maintaining robust euglycemia. If they're starting to have sugars that are in the upper 50s, still enough that you feel like you can wean, but not, 60s or 70s or higher, you might decrease by 1/2 an mkm. So you might decrease your rate by 1 ml an hour, and do this until you can get the baby safely off the dextrose containing fluids. Sometimes you might have to hold. They might not have 2 sugars in a row above 55, and you might need to leave your rate where it's at. Sometimes you might even need to go back up. And we would recommend doing that the same way you weaned. So if you had just weaned by 2 mLs an hour and now you have some hypoglycemia, go back up on your rate by 2 mLs an hour, which in this case would be 1 GIR. So we really don't recommend weaning by any kind of increments of the volume. Weaning in a way that's driven by the glucose infusion rate is what's going to be best for the baby. I sometimes hear from providers, oh, we decreased the fluids, the rate in 1/2, and the baby was still euglycemic. So then the next morning we turned them off, and then they got rebound hypoglycemia. Or we were running at 80 MKD, and we went down to 60, and then 40, and then 20, and then off. And anything like that is likely going to be too big of jumps for the baby, and they're not going to be able to maintain euglycemia. Their pancreas isn't going to be able to adjust. So you're going to precipitate a rebound hypoglycemia. So that's why it's really important to follow the baby's blood sugars before every feed, make sure they're still euglycemic, and then wean in a fashion that's driven by their glucose infusion rate. And then, of course, if you're having trouble obtaining or maintaining your peripheral access, if the baby has persistent hypoglycemia, or if any other issues come up, we're always happy to talk through things with you. And certainly happy to try to find the baby, a spot in our neonatal ICU or one of the others in our area, if that's what's indicated. So I hope that was a little bit helpful in terms of just how you maybe could keep a baby there at a level 1 and wean them off IV fluids without persistent hypoglycemia, using the GIR to guide your weans. And that's it. If you do have any questions, happy to hear them.
So with that, I'm going to leave the slides up just in case we need to revisit them. I'm going to see if I can see the chat. Feel free to either put your questions in the chat. Oh, no, apparently I can't. Or just turn your mic on and ask a question if you have it. And I am curious to hear how you guys feel about keeping babies with gestational diabetes, either on medication or not. So I'm just curious to hear what your thoughts are.
I see a question asking if we will send the presentation.
Yes, I will be sending out the slides along with the recording.
Do most of you guys that are on the, again, I can't see anything here. I'll stop sharing in a minute, but do any of you guys send everybody on medication to us? And I'm curious if this helps at all in terms of maybe keeping them at your place.
Hi, Marge. It's Bridget Bromersky down at Southwestern Vermont Medical Center. We do not ship everybody. We are, we do pediatric consults, for our class A2 gestational diabetics and our pre-existing. All this data is really comes, you know, really hits home, especially for some of these moms whose glycemic control is not as good. I'm a NICU nurse for 25 years and now a nurse practitioner. So and GIRs and weaning is exactly what I love to do and what we do with these kids. Aggressive feeding is exactly right. I use NG tubes a lot if I need to. I'm not afraid to use extra calories or, you know, give some extra calories in human milk as well. And you know, the biggest hope is the perinatal education regarding this, because it's such a real concern for the need for kids, for the newborns to need a higher level of care. So, you know, I always say in the obstetric world, there's times that you know, obstetricians do a beautiful job delivering babies, but sometimes from a neonatal standpoint, we can't always, you know, keep these kids in a level 1 nursery. And that's who we are. That's, you know, but the ability to do, you know, glucose management is something that we as pediatric people in Bennington really do work very hard at.
That's great. Thank you. We do have some questions in the chat. I didn't know if you had anything else you wanted to say in response to that, Marge.
No, sorry, I was responding to a clinic question. Did you have a specific, I heard, Bridget, that you talked a lot to moms about control and weight gain, but did you have a specific question?
No, I was the question about the slides, because I do like to educate on GIR and weaning and stuff like that, and making kind of like better CPOE orders so that people can understand them and follow them. So that'll be helpful when I have them in front of me for the Department of Pediatric meeting. Thank you so much.
Yeah, of course. There was a question that it looks like it's kind of directed for you, Marge. Have you had any mom patients on CGMs for glucose monitoring?
Oh yeah, we have a lot, but they're all pre-existing diabetics. And our hospital JCO rules are such that we are not allowed to use CGMs for clinical care. I would say that, especially because it's not as clear for the diet people whether or not you need to check it at all. I personally, as long as you don't act on it, I think if you just want to track it that way, I wouldn't necessarily put it even in the medical record. There were some issues with that, that's all. We do not use a lot of CGMs with our gestational diabetics. We have a lot of insurance company problems, and honestly, you know, it's hard for us to go to the mat for that. So yes, we have them. No, we can't use them. I tell that to even our type 1 diabetics and stuff that have a lot of CGMs. So now, if people are on a closed loop pump system, they're allowed to continue it that way, but we still have to finger prick them.
Then I have a question. How would this paradigm change with co-occurring NAS for an AGA neonate? It wouldn't. How that baby is managed, will depend on your center, whether you provide morphine, whether you do eat, sleep, console scoring versus Finnegan scoring. But these would be two separate, true but unrelated problems, and how much of it was managed at the level 1 newborn nursery center would really depend on the comfort of your staff and your practitioners and what you had available to provide for the baby. So again, we're always happy to talk through any case with you and accept any baby who needs a higher level of care. But that shouldn't necessarily impact the glucose monitoring and treatment. And I see, if a baby needs extra calories to maintain glucose control in the first 24 hours of life, when would you wean back down to 20 cal? That's a great question. I love that question. I think it really depends on the baby. So if as soon as you fortified to 24 kcal, you had euglycemia and you had euglycemia on every subsequent check, I'd be comfortable weaning back down to 20 pretty quickly, even within the next couple of days, like 1 to 2 days. Sometimes it's good to time it along with when mom's milk comes in. So if this is a primip and she really doesn't have her milk come in until like day 5 to 6, you might wait a little bit longer until you know that she has a robust supply. But there are cases where we have babies who have more persistent hypoglycemia. And again, those are likely coming up to us and not being managed in your hospitals. But where we sometimes will discharge them home on the 24 kcal, and they might stay on that, in some cases for more than a month. But that's rare. I think most of the time you can get off it within the first couple of days, and certainly within the first week.
Is there any other way that you guys need us to help support you in terms of, keeping people there for delivery?
Hey, Marge, this is Anna. I just wanted to throw out there, similar to what Bridget described, we're doing at NMC. And if any of the other community hospitals have questions about staffing for nursing or anything like that, on how to, make the pieces work, I'd be more than willing to have a conversation with them to help support keeping the families in their community.
I think one of the, or some of the biggest barriers that I see, at least coming up with the neonate, are, it seems like some places kind of have almost time limits, don't feel comfortable keeping a baby who still needs an IV after a certain amount of time. And related to that some, places, it can be a real challenge to get and maintain good peripheral access on these little babies. So certainly, if folks at the centers who have more experience, if those are things that you want to speak to, how you're able to, have folks staffed and trained and everything to a point that they're able to get that access when needed and keep it. I think that's often, a very real challenge for a lot of hospitals.
Thank you very, very much. Oh, this question.
No, I don't have a question.
Thank you. I really appreciate you coming back to us. That's it. Go home.
All right, so are there any additional questions? I don't see anything else in the chat. If there's not anything additional, then want to remind you all that I will be sending out this recording as well as the slides and a link for evaluation. So that should be coming to you all shortly. And as always, feel free to email me or Marge or Delia with any of your additional questions. And I will make sure any questions get to the correct person. So thank you all.
Thank you.